for joining today. This is a talk in our Questions That Matter in Medicine series. And what we're going to talk about today is the ethics of restricting liberties in medicine and public health. And for this, I'm going to use the case of vaccines. And I'll get to defining what I mean by a mandate in a moment, because that actually turns out to be somewhat important. I'll just say, however, that vaccines are far from the only example of this, right? During the pandemic, we saw school closures and business closures and masking requirements and quarantine and isolation and placing patients on mental health holds happens in medicine. So the broader question that I'm going to be looking at in this conversation is why is it that medical professionals, public health professionals, would have the social power to put people to restrict people's liberties, right? To put people in a mental health hold. What gives health professionals the right to do that, to tell people what to do? These are, by the way, called the police powers of medicine and public health, and they're named that for that reason because they are comparable to the powers that the police have to put people under arrest. And so this question of, what gives us the moral and the legal right to put people essentially under arrest or to restrict their liberties in some way. What is it that allows us to do that? This comes in the context of a broader set of ethical issues that arise during outbreaks and pandemics. They also frequently arise during other types of public health emergencies. I've called these the three R's of ethics in epidemics, and there are issues here related to rationing of scarce resources. That's a frequent dilemma during public health emergencies of all sorts, whether you're talking about, a hurricane or an earthquake, or whether you're talking about an outbreak of an infectious illness. There may be a time when there are more people who need a resource than are able to get it. So there's a whole set of ethical issues around rationing, which I'll touch on in just a moment. The second one is the one we're going to focus on today, which is restrictions on liberties. The third one I'm not going to talk about today, but that is about sort of professional responsibilities to continue caring for patients when you face personal risk. So the extent to which doctors, nurses, other health professionals have responsibilities to put their own lives and well-being on the line in order to continue caring for the ill. That's a separate set of issues, although again, all of these are somewhat related. So I'm going to say a word here about rationing because there is a particular principle that comes up a lot in the rationing conversation that also is applied in the restrictions on liberty conversation. Um, and I'll just say, we have dealt with extreme forms of rationing in the very recent past, where, there were not enough ICU beds and there were concerns about not having enough ventilators. There were certainly not enough nurses and doctors to do all of the work that needed to be done. So we've had to make difficult rationing decisions just in the last few years. Even last year, by the way, there was a blood culture bottle shortage. And if you go on the FDA website right now, you will see about 100 different medicines that are currently being rationed in one way or another because they are in shortage. So rationing is a common issue that we actually deal with all the time, even outside of pandemics. But it has a great history in terms of rationing with regard to outbreaks and infectious diseases and with regard to vaccines. For those of you who would remember 2004, there is one plant at that time in England that made half of the flu vaccine that was used in the United States. It was the Chiron plant, and that vaccine stock ended up getting infected with a Klebsiella, a bacteria, and the entire productivity of that plant went out of service for a year. And so the US flu vaccine was cut in half. It was an odd shortage in that if you happened to get your flu vaccine from the Chiron plant, you got none. if you happen to order your flu vaccine from the other plant, the US-based plant, that one was fully operational. And so you could have two hospitals or two clinics across the street from each other or down the block from each other, one of which was fully stocked and the other of which had no vaccine whatsoever. So this raised a lot of questions about how to allocate vaccines across sites and who was supposed to get the vaccine first. And obviously, with the flu vaccine at that time, you can see by the lineup here, age was used as a factor in terms of who was going to get the vaccine first. Um, so let me just put a question up here, and I'm not going to ask people to vote on this, but I just want to pose this as a sort of hypothetical question almost, because it is such a frequently asserted statement that in a catastrophic disaster, medical ethics becomes much more simple. Normally, you all, the medical students on the line here have been learning about medical ethics, and you've talked about balancing values like autonomy and beneficence and non-maleficence and justice. Um, and it is very common, even for people who do a lot of work in public health ethics, for folks to say that, yeah, that's for normal times, where you have the luxury of thinking about all of these different values. But in a disaster, it all boils down to saving the most lives. And public health ethics in disaster circumstances should be purely utilitarian. And I'm going to argue that B here is the correct answer, although I suspect a few people are tempted to guess C, that all of ethics is subjective and personal. And so any answer you want to give, you can find a justification for. But I'm going to argue that B is actually the correct answer here, that even though it is tempting to want to make things simple in a disaster, unfortunately, things don't get simple. If anything, in fact, they often get even more complex, and we are forced, even during disasters, to balance a variety of values, including the value of efficiently saving as many lives as possible. But there are other values that come into play. And I'll give you an example that I think is about as extreme as you can get. This is Memorial Hospital in the wake of Hurricane Katrina. And so in this setting, you are, without power. You are without, therefore, um, cooling, which in New Orleans in September means the inside of this building is, over 100 degrees, extremely humid. You can see the water pooled on the floors. Um, it was an absolute catastrophic disaster. And this is the scenario in which you might think, okay, the people who are there, all they're going to care about is just saving as many lives as possible. This is a picture of where they had to move the morgue because the basement was flooded. So the morgue space was the chapel. And if you were, and this is, I admit this is a kind of extreme example here, but if you really cared only about saving the most lives, then any person who was not expected to survive, anyone who was black tagged in the triage process here and was not expected to survive, you should just move them to the morgue, right? Why would you give them any morphine? Why would you give them any time or any resources at all? If all you care about is saving the most lives, you should save all the resources for people who have a chance of surviving. Now, I hope it's needless to say that is not what actually happens in disasters. We don't completely ignore the needs of people who are dying. We continue to expend time and other resources on people who are dying. So one of the reasons why I think B is the correct answer is that, in fact, when we are faced with these types of ethical dilemmas, we don't go full utilitarian. We still care about other things like dignity and comfort and equity and so on. There are other reasons, however, too. For one thing, utilitarianism is actually very hard to implement in the real world. Utilitarianism is based on the idea that you're getting the greatest good for the greatest number, but what counts as the greatest good, right? A utilitarian might easily argue that we aren't just trying to save the most lives, we're trying to save the most life years, right? Which might argue for putting younger people first. Or maybe a utilitarian would say that we want the most productive or quality life years, which leads into all types of challenging ethical and practical considerations about what counts as a quality life year. And is that really fair? And right, so I just put these up as examples. I'm not going to answer this question because my answer to this dilemma is that you can't just use utilitarianism. In fact, some of the things that we care a lot about can be boiled down to consequential reasoning, but some of them are more foundational, things like dignity and respect. And this is just one of the problems with sort of simple solutions to complex problems. Triage and rationing decisions in disasters are complex problems. They are not amenable to a simple solution where you just say, this is the only criterion you're going to use. Um, the other thing that happens is there are these other values that are actually considered. So I'll just put these up here. Do we really need to ration? Is it necessary? What about issues of equity and social justice? Do we want a rationing schema that might make the worst off even worse off? Right? Or is there a role for promoting some form of justice in allocation decisions to try to save those who are already who are the more disadvantaged? What about maintaining social order? There are reasons, for example, why many of the triage protocols that were developed for COVID would have health professionals, public service professionals, first responders, and so on having some degree of preference in receiving limited resources because those are people who could potentially get back to work and help others in their recovery. Economic impact certainly comes into play. Maintaining a good society. I'll say in Colorado, our COVID resource allocation guidance that we, rewrote in the first months of the pandemic was very explicit about this, that we wanted to make triage decisions, if it came to that, in a way that would allow for society to come back together and heal in the wake of the pandemic. We thought that was an important goal, was to have triage protocols that were understandable and that people would see as fair and so on. So, when we are faced with a shortage, one of the core principles often raised across public health ethics is the principle of proportionality. And the principle of proportionality is the idea that you would only ration things if you absolutely needed to. And as soon as you don't need to ration them, you would stop and you will try everything first, right? So, as this couple shows, and this is from the SARS outbreak in earlier in the 2000s. So the original SARS-CoV-1, um, that we will try everything. We will, try novel strategies. We will share resources. We'll do whatever we can to avoid having to ration. And that's appropriate. That is the principle of proportionality. And again, going back to Hurricane Katrina and resource allocation, the principle of proportionality played out here in Louis Armstrong International Airport, where a number of people were black tagged, meaning they were not anticipated to ever be able to be evacuated from the airport because they were expected to die before they would be evacuated. And you can see on the leaders here the red tags. These are people who are anticipated to survive and are likely to be evacuated, but others were anticipated to die and were therefore not at the top of the list for evacuation. As it turns out, only a few of those patients actually died. Many of them survived. Many of the black tagged individuals survived and were evacuated. The reason for that is that new resources arose, right? The availability of transportation increased, and some resources were brought into the airport so that those people could be better treated while they were waiting for evacuation. So very few of them actually died, and that's a testament to the value of the principle of proportionality. People with a black tag are not just black tagged and set aside. They continue to receive some care, and as new resources arise, they get re-triaged, and they ended up in this instance doing well in general. So the principle of proportionality is, don't use a sledgehammer if a fly swatter will do. Don't use a chainsaw when a pocket knife will do. That, you've heard those kinds of sayings before. In sort of public health speak, this is use the least restrictive means of achieving the goal. So you want to, in the context of rationing, that's true. And also now we're moving into the restrictions on liberty. You also, in restrictions on liberty, want to do the least you need to in order to accomplish the goal. So let's talk about restrictions on liberty now. And I mentioned already, I'm going to use vaccines as my case example here, although there are many other case examples that could be used. So I'll start with a few of the arguments in favor of vaccine mandates. We'll also talk about objections to vaccine mandates, and we'll talk about what is a mandate after all, anyways, what counts as a mandate. So you can't really talk about mandates, governmental mandates in the US without a little background on the US Constitution, which limits what the state can do to require what the state can, require people to do. So under the Fifth and the 14th Amendments, you've got rights to equal protection and to due process. And in a series of cases, the Supreme Court has basically said that restricting individual liberties by the state can only occur when there is a compelling state interest, when the intervention is well targeted, so least restrictive and targeted only to where it will make an impact. And there has to be a due process provision, so people have to be able to challenge the taking of their liberty. This, by the way, is not just seen in the US. Back in the early 90s, the UN called together a group of people. Sorry, this is in the 80s, actually, I believe. Called together a group of international legal scholars because there had been a series of dictators, basically, who had come to power in countries and then used the argument that they were trying to protect the public health as a way to shut down civil discourse and prevent resistance, civil resistance to their regimes. And so the UN also came out with a set of principles, legitimate, legal, necessary, and non-discriminatory, and the least restrictive means appropriate to achievement of the public health goals. So you'll see these are very similar to the American Constitution. So I think these are, globally speaking, these are pretty good as ways of thinking about when is it okay to restrict a community or an individual's liberties in terms of trying to protect the larger public's health. They all derive, by the way, from John Stuart Mill, the original libertarian. Um, John Stuart Mill had what he called the harm principle, and that is what underlies all of public health police powers, right? So the answer to my question about why are medical and public health professionals empowered to infringe on individual liberties, it is the harm principle that empowers this. And that is that this, by the way, is often characterized as your liberty to swing your hand around ends at the tip of my nose, right? So you have liberty, but when you start hurting other people as a result of that liberty, that's when your liberty can be restricted. And I've just listed here the various ways in which individual and community liberties can be restricted by the public health community, by individual doctors even, in terms of things like isolation and quarantine or M1 holds, which is what we call a behavioral health hold here in Colorado. But they also allow for property seizures and vaccine requirements and epidemiologic investigations and social distancing measures, business closures, school closures. All of these things fall under these public health police powers. And all of them require that the exercise of the restriction of liberty needs to be an effective way of accomplishing the public health goal. So let me just put that on the table first. The number one criterion here is whatever you're doing, it has to work, right? If it's not going to work, then you have restricted liberties without achieving the public health goal. So that is a primary consideration. And I'm going to get back to why it's a problematic primary consideration in just a moment. Not that it's wrong, but it's problematic. Um, these issues go back a very long time, even before this case. But this is the most famous case by far in terms of restricting liberties and specifically around the context of vaccination. So this case, by the way, for the medical students in the audience, this is totally worth reading. It's like 2 pages. It's a really short Supreme Court argument. But the argument that they make here is essentially that of sort of public protection, public self-defense is what they call it. And the idea here, and this was a case around smallpox vaccination. In 1902, there's a big smallpox outbreak in Boston, and this Reverend Henning Jacobson refuses to be vaccinated. There is a fine of $5 if you refuse to be vaccinated, and we'll come back to whether that counts as a mandate in a moment. But suffice to say, $5 in 1905, which is when this case was decided, would be about $300 today. So a $300 fine if you refuse to be vaccinated. He argues this case, saying this is my right not to be vaccinated. You can't tell me what to do. I don't believe the vaccine works. He made all of the arguments that people who decline vaccination frequently make, I think. And by the way, he was right about some of these things. Smallpox vaccination was quite dangerous by comparison to contemporary vaccines. The smallpox vaccine at that time, was a live virus, cowpox. And so it could cause very serious illness and fairly frequently did. But what the Supreme Court argued was that we have to be able to restrict some people's liberties in order to secure liberties for everyone. So the argument they're making here is basically the argument that allows the state to put up stop signs or have speed limits on the freeway, right? Yes, a stop sign is a restriction on your liberty to blow through the intersection without stopping. But if people don't agree to allow their individual liberty to be restricted in that way, everyone will end up being harmed. And so, as they said, I put it on the sidebar here, real liberty for all could not exist under the operation of a principle allowing everyone to do everything that they want all the time, regardless of the injury done to others. And so they make this argument that real liberty for all requires that we all agree to some rules of the road for everyone. So that's one case example. Let me jump to another case example, which the medical students will have seen this example already. And this is, I think, the paradigm case of an overextension of public health police powers. This is the case of Buck versus Bell. Carrie Buck is a young woman who is in the care of a caretaker because her mother is institutionalized with cognitive disabilities of unknown sort. Carrie ends up becoming pregnant. She was, in the end, probably raped, and that was how she became pregnant, perhaps by the nephew of the people who were taking care of her. But in the end, she gets sent to an institution and she has her baby, and then she is assigned to be involuntarily sterilized. Now, I'll just say, when comparing this to the vaccination case, she did not have to pay a fine if she refused. There was no option to refuse. So this is clearly a mandatory action by the state to compulsorily sterilize Carrie Buck to prevent her from having any more babies. And I've highlighted the last couple sentences. One of these sentences, a very infamous sentence, three generations of imbeciles are enough. That refers to Carrie's mother and Carrie's child. Those are the three generations of so-called imbeciles. I will say, by the way, Carrie's child died at the age of, I believe, 8, so only got to second or third grade, but was not an imbecile. She did fine in school. Carrie herself had done fine in school as well, and she lived to an old age, and no one who met her subsequently thought that she was categorized as an imbecile. But this was the case that was brought, and the argument was made that all of these, and that she would continue to have children who would have cognitive disabilities, and that that was a danger to the state. So this is the other sentence that I've highlighted here. I don't know if you can see my arrow, but the principle that sustains compulsory vaccination is broad enough to cover cutting the fallopian tubes. So this was a public health case, argued under the same premises as the Jacobson case. Jacobson is cited in this case. Um, and the Supreme Court is saying not only, can she be required, but it can be compulsory. She can be physically forced to have her fallopian tubes cut. So this, to me, seems like it is sort of at the opposite end of the use of the public health police power, right? And so the question that we are faced whenever we think about restricting individual liberties in pursuit of the public good is, where does it sit in that spectrum between Jacobson and Bell? Is it more like it's really obvious this works and it's, relatively safe and effective and it will prevent other people from getting ill and it's completely rational and reasonable? Or is this an overreach of public health police powers like forced sterilization, where, the forcible nature is too much, where the degree to which it will work is radically unproven, shall we say, since this was all based on theories of eugenics, which had not at that time been proven out and have subsequently been debunked broadly. So where does it sit, right? What is the evidence that it will work? What is the degree to which restricting liberties is going to take place? How are we going to know whether it's working, and so on? And that goes for masking, that goes for travel bans, it goes for quarantine, goes for business closures, it goes for vaccination. So all of these questions are really in that spectrum, right? And so, let me say a word about some of the objections that we typically hear to mandatory vaccination, and they tend to fall into these two buckets. They're typically very much mixed, and I find it helpful to separate these out into these two buckets. There are ideological objections, or what a philosopher might call deontological objections, right? These are objections that you are not the boss of me, that it is alienating and disrespectful and an infringement on my personal liberty for you to tell me what to do. And that is a standalone argument, which is separate in some ways, although again, often conflated with these sort of utilitarian arguments. Some of these utilitarian arguments are around your strategy is not going to work. If you tell me what to do, I am less likely to do it than if you ask me to do it. And I'll give you some data on this in just a moment. And there are other ways in which a so-called mandate might actually backfire because it really calls attention to the people who are objecting, which typically in a vaccination scenario is a small number of people. A relatively small number of people object to vaccines. That's always been the case. It's a relatively small, now might still be big enough to make a big difference, but it's a relatively small number of people who object to vaccination. So maybe you would do just as well or better by using voluntary efforts. And they often talk about trust and distrust, and its impact on achieving the utilitarian goal of maximizing the number of people who are actually vaccinated. And here's a central point. It is very tempting for us in medicine and in public health because we are trained in epidemiology and in infectious diseases and in things like, transmissibility and R naughts, right? How many people are going to catch this disease if one person gets infected, the latency period, the duration of infectiousness, and all of these things matter in terms of how well restrictions on liberty might work, right? If you are trying to, I'll give you one quick example here. If you are trying to quarantine people or isolate those who have been exposed to SARS, you might go looking for people who've been exposed and put them all in quarantine. The problem there is very few of them ended up ever, and we did, this happened. Very few of them ended up actually being infected. Some of them end up getting infected while waiting in line to have their temperature checked. So it turned out, not to work very well on a biological basis. So trying to implement a restriction on liberty actually ended up backfiring on a biological basis. But more likely is that things will backfire on the basis of social characteristics. So effectiveness of a quarantine is going to depend on whether people are willing to be quarantined. In the US, we have a whole lot of people who have, their own guns and their own four-wheel drive vehicles. And if you tried to, put a cordon sanitaire around Denver and say, there's an outbreak in Denver, we're going to close it down, not let anyone come or go, you would have people taking off. And in fact, this is what has been shown to sometimes happen. This is a report that I was working on with a committee at the National Academy of Medicine right before the pandemic. We did the work on this report over the basically 18 months before the pandemic arose. So come, February of 2020, we ended up having to write a whole new chapter for this report. But I was largely involved in this chapter on what are called what are called non-pharmaceutical interventions. So these are things like quarantines and travel bans, and so on. And one of the things that we noticed was that people who fear being placed in quarantine can sometimes flee the area, potentially spreading the contagion even further than it might have spread if they had not been threatened with quarantine. And what we noticed were examples like the SARS epidemic of 2003, which, by the way, is, the original SARS virus had about a 10% mortality rate, so it was quite a lot more deadly than SARS-CoV-2 ended up being. But it did not spread worldwide, and there is a specific reason for that I'll tell you in just a second. When the SARS epidemic broke out, one of the big epicenters of the outbreak was the Amoy Gardens apartment complex that I have a picture of here. It's an enormous complex in Hong Kong. And a number of the original cases in Hong Kong were in this apartment complex. And so there was a plan first to quarantine all of Beijing, which led for 245,000 migrant workers to flee the city. And then when there was a threat to, excuse me, to close the Amoy Gardens apartments to any traffic in or out, they were going to put, police officers around. They sent police to the apartment building to establish this cordon sanitaire, and half the apartments were already empty by the time the police arrived, because people heard that this was going to happen and they left. After all, no one wants to be stuck inside of a quarantine with other people, some of whom may be sick. So it just, it was a terrible disaster in that sense. And by the way, a very similar thing happened when COVID arose, right? By the time Wuhan, China was locked down, this is a city, Wuhan, of 11 million people. By the time the cordon sanitaire was established around Wuhan, it was a half that size. So over 5 million people had fled Wuhan in the fearing that a lockdown was coming. Now, let me just say a word about health professionals in particular, because I've made an argument here for very limited restrictions on liberty and very limited requirements for people to receive vaccines. And I just want to side note that health professionals are a different category, in my view, and that's because health professionals, have sworn to do what they can to prevent illness and injury and to help their patients. So to me, the proposition that healthcare workers could be required to be vaccinated is much easier to sustain than the proposition that the general public should be required to be vaccinated in any way. And that is, again, because of the fact that we are in contact with vulnerable populations. If even if the COVID vaccine or the flu vaccine or any other vaccine is relatively modest in terms of its impact and its effects, I think we have an obligation. We have an obligation to not put our patients at even a small incremental additional risk unless we absolutely have to. So obligating health professionals is a different question in my view. Um, that said, let's get now to this question of mandates. And when should mandates be used? I will say mandate is usually in this context used more for rhetorical than it is for descriptive purposes. There have been debates over vaccine mandates for things like the HPV vaccine, where in some states there is literally no penalty whatsoever and no process whatsoever. All you have to do is say no, thank you, and you don't get the HPV vaccine. Um, that to me is not actually a mandate. And the only reason it's called a mandate in the legislation is because a mandatory vaccine has to be covered under the Affordable Care Act at full cost. And so if you call it a mandatory vaccine, it gets coverage under ACA plans. If you don't, it doesn't. And so it gets called a mandate, but it purely has to do, and that to me is problematic, actually. I would rather use the word mandate with some degree of meaning, even though I recognize that public health really sits at the intersection of medical science and public health and politics, right? It is the intersection of medical science and politics. So the language of public health often blends these sort of scientifically descriptive and rhetorical purposes. And you see this a lot. There are debates about this, like, people who are in favor of harm reduction strategies call them harm reduction. People who oppose them call them harm maintenance strategies, right? And that is just a rhetorical use of terminology in a way that you think is more likely. And by the way, I'm not criticizing that. I think that is necessary and it's an inherent part of communication, right? Is rhetoric, using words that resonate, using words that mean what you hope people take away from them, and so on. But it does lead to problems when you're talking about a word like mandate, which, if you think about the word mandate, it means to hand down. It's a command, right? It comes from manus and dare, to get to hand a command down. So it's not just a recommendation. It also, in my view, is not necessarily an absolute requirement. So unlike the Buck versus Bell case, where that was truly a complete mandate, right? Compulsory. She had to be sterilized and would be, you know, dragged kicking and screaming if she didn't agree. On the other hand, most of our so-called mandates, they're not federal mandates, right? There are no federal vaccine mandates. They're state-based mandates. And they are mandates based on things like work environment for health professionals, or they are childhood vaccinations, where mandates have been implemented with penalties, right? Not being able to go to school is a real penalty. And they have been implemented for a very specific set of reasons. Number one, they are incredibly effective, Right. I just circled the HIB vaccine, Haemophilus influenza B, because this happened to take place while I was in medical school. So at the beginning of medical school and in my first clinical year, I was still seeing patients, children with Haemophilus influenza meningitis. It was one of the top causes of childhood deafness at that time. And you can just see, within a couple of years, by the time I was a resident, there were no more cases. It was just gone. And we just don't see Haemophilus influenza meningitis anymore because of the HIB vaccine. Now, that may change, right? If people stop being vaccinated, then we will start to see this go up again. And this is, the challenge of childhood vaccinations in particular. Vaccine mandates are sometimes thought to be necessary, found to be necessary, because education either requires a high level of fear or it requires constant resources and effort every year to convince each new generation of parents that it is worth it to avoid this outcome, which, by the way, you don't see anymore, right? We don't see polio anymore. We don't see diphtheria anymore. We are starting to see some measles, but as risks decline from these vaccines because they are widely used, persuasion becomes increasingly difficult, right? Because persuasion depends to some degree on belief that there is actually a threat out there. And if you don't see that threat emerging, it is harder to convince people to do something, even if the perceived risk of the vaccine is pretty small, even if it's just, the pain of the shot or the annoyance of having to go in and get the shot, or, right, the many reasons why people choose not to get vaccines have nothing to do with their, not believing that the vaccine would work, but they don't believe there's much of a threat. They believe everyone else is vaccinated. They don't like getting shots or they don't have time to take off work to take their children in to get shots. All of those things, right, make it so that you actually need to have a penalty in order to get people to get these vaccines and to maintain the levels that are necessary for herd immunity, which is what allows those people who can't get vaccinated to survive healthy in the world, is that there's not circulating virus out there that they are going to be exposed to because there's herd immunity. So I'll just say these are my answers to these questions. And I'll tell you that other people are going to have different answers to these questions, which is fair. But for me, I have a two-part test for what I would call when I would call something a mandate. I think there has to be an explicit process for saying no. So it has to be an opt-out process. The standard is that you get it. And in order to opt out, you need to go through a specific process with some degree of a penalty. Now that penalty could be rather mild, but there needs to be some penalty, or I don't think it's actually a mandate. And then where should mandates be used under that definition? I think a mandate makes sense when, number one, there's clear medical value to the individual in the absence of herd immunity. So, if the virus were out circulating right now, would you get vaccinated based on its own value to you? If the answer is yes, then you should be getting vaccinated in order to sustain herd immunity. But number two, I think also public health benefits need to be clear. So herd immunity needs to be achievable. And this is important because that is not always the case for all illnesses, right? And then finally, I think the mandate needs to be the least restrictive means of getting to optimal levels of vaccination. So you need to have tried some other strategies first, um, before implementing the mandate. Let me just say, using these criteria, which I had written about a decade before the pandemic, more than a decade before the pandemic. So I was ready to opine on whether mandates were valid and ethically supportable during the COVID pandemic. And here's what happened. Um, in November of 2021, I and others in the Association of Bioethics Program Directors wrote for health fairs about why vaccine mandates for COVID-19 vaccine at that time were ethical. And less than a year later, we wrote a second piece saying they're not ethical anymore. And the reason wasn't that our rationales had changed. The rationale was the same. What had changed were the underlying facts, right? The virus had changed and the population had changed. So we no longer believed that herd immunity was going to be possible. We were convinced that it was not possible. And most people by that time had already had either vaccination or or infection or both. And so on the principle of proportionality, that you only would implement a mandate if it is the least restrictive way to get to where you're trying to go, we thought very quickly after saying a mandate is reasonable, that a mandate was no longer reasonable. That is normal in public health and in medicine, that things that we think are reasonable today, we are scientists. We are not ideologues. As the data change, we change our minds. And that is a valuable thing for people to actually see and understand, is that is a core characteristic of being a scientist, is the ability and the willingness to change your mind. I think another core characteristic of being a good scientist, and now I'm using the word good to mean not just good in the sense of skilled technically, but in the sense of ethically good, is to be able to acknowledge when you have got things wrong and say you're sorry. So let me just give you, by way of example, a few of the things that I got wrong. I was very convinced at the beginning of the pandemic that steroids would not help. We had some experience with steroids in ARDS, and that's what very severe COVID was looking like. And I was, completely wrong. Turns out steroids were very useful in critical illness. I was pretty hopeful in March and April and even May that hydroxychloroquine might turn out to be a cheap, relatively safe intervention that might be beneficial. It failed repeatedly. It just didn't work. I was very convinced, and by the way, these next two are related. I was convinced that we would get herd immunity from the vaccines and that boosters were worthless, but that pharma was pushing them in order to get more money. That was my cynical view of the pharmaceutical industry at the time. And I thought, we just need a really good vaccine, and this is going to act, more like measles than like the flu. I was wrong on both counts, more like flu than the measles, and boosters help, especially for high-risk people, even people who've already had vaccines. You can ask anyone who knows me. I get a booster, annually, and as I get older, I'll probably get one twice a year. The data are very clear. They're not perfect, but they help. And I don't see any reason why I would prefer to get sick than to get the booster. Getting COVID is very unpleasant. I've had it twice. I didn't like it either time. Um, and finally, this last one. Um, I have a very clear memory of a phone call early in 2020 where the Governor's Advisory Committee on COVID response was having a Zoom, phone call. Um, and we were talking about implementing a statewide mask mandate for people in public places. And, there were a lot of people on the call, but I was the only one who brought up this question of, you know what? A mask mandate could actually backfire. We have examples of where mandates have actually pushed people to not do something that they would have done if it had not been forced upon them. Um, and uh, and I am sorry that I didn't push that harder. I ended up voting for that for the mask mandate, and I regret it in the end. Even though, by the way, masks absolutely work. So just to be very clear on this, I wore a mask throughout the pandemic, an N95 whenever I could get one. Um, and the physics of masks are very clear. If worn properly, they work. What doesn't work are mask mandates. Policy doesn't work. masks work. So if you want to prevent yourself from catching COVID and you're going into an environment where you think you might be exposed, you should absolutely wear a mask. But as a policy matter, implementing a mask mandate does not change the number of people. We have a lot of data on this now. Mask mandates did not have much of an impact, if any. Um, and that's true, even though masks work. And I regret that I didn't push that harder. I think there are probably others who were more involved in conversations like about school closures who probably have regrets now too about, not pushing a little harder to get schools reopened once it became clear of the type of harms that were being imposed on kids in order to try and protect the rest of us, which, again, these are not easy decisions. They're not, a piece of cake, and it was obvious at the time. It's very easy today to do, backseat quarterbacking. That's a mixed metaphor. It's very easy today to look back, with 2020 vision. At the time, I think, we were trying to do the very best we could with the information that we had. But that doesn't mean that, we did not make mistakes, including me. So I am sorry for that. And I will now stop. And I think we have a few minutes for Q&A. So I'll stop the share as well so I can see your beautiful faces.
Matt, I wasn't sure if we were going to have time for questions, so I told people no, but now I'm asking for them in
Oh,
the chat.
well, I see Linda Collison put in as a comment, a smallpox vaccination was not an obvious candidate for a mandate. And I think, to some extent that is true in the sense that the smallpox vaccine was a pretty dangerous vaccine at the time. Smallpox, however, was an exceedingly dangerous virus. And so, I think even in retrospect, I think a mandate was certainly justifiable. But it may be that, for example, I could make a stronger case that measles vaccination mandates or diphtheria. Let's go with diphtheria, which has an even higher mortality rate and is also the vaccine is extremely effective, right? So we have a bunch of things that pose, less risk than the Jacobson case was envisioning in terms of the smallpox vaccine, and more benefit. Um, but uh, but I guess I wanted to use those cases because those are the seminal cases that really frame the debate. Even though I think, Linda, you're probably right. There are probably better examples. At least there's a better example on that end. I don't know if there's anything worse than the Bell decision the Buck versus Bell decision in terms of the egregious violation of individual liberties. In pursuit of a public health goal that was unachievable. Oh, yes, Sean Sibley is asking about the most in the COVID-19 mandates. Yeah, that was a reflection of my sentiment and others that health professionals, there was still an argument at that time to ensure that health professionals were vaccinated because of our interactions with very vulnerable people, our frequent interactions with very vulnerable people. And COVID does not perfectly make you sterile, obviously, in terms of immunity. It doesn't prevent you from catching it entirely. It doesn't prevent you from transmitting it entirely, but it definitely reduces your risk of both by by a marginal amount. And by the way, even at that time and still today, it's not clear exactly what those reductions are because this disease keeps evolving and we keep evolving. So the amount to which it reduces risk of catching the disease and transmitting it for someone who has caught COVID 5 times is probably different than it is from someone who has never caught COVID, you know, or someone who has been vaccinated all the way along the line. Do you think by reducing mandates, misinformation will be more predominant? since it appears as the government health department is no longer taking a stance. Um, and isolation from polio. Yeah, well, hmm. Yes, I think we did have some data from the polio era. I'll do that one first. I think we do have data from the polio era that closing schools was damaging to kids. I don't think that those data were assimilated as well as they probably should have been into the deliberations, which, and here I'm a little outside my area of expertise, but I think those deliberations became incredibly political and they were dominated by teachers unions who are very powerful and politicians who are very powerful and not so much by the public health enterprise, which is why I say I don't actually think school closures were things that the public health enterprise was pushing that much for. They were being pushed in other spaces. Um, and then Joe's question about misinformation becoming more predominant if we were to pull back on mandates. Um, you know, I think that mandates are problematic in terms of misinformation because they call attention to the fact that people are being required to do something and that they don't want to do. And so they do have that problem of calling attention to the objectors. And so there is a way in which having a mandate can actually raise the profile of the objectors. Unfortunately, right now, today, the profile of the objectors is so extremely high. I don't know that mandates are even in the realm of, having any impact on the information disinformation problem. My hunch is that what we ought to be focusing on today is recognizing that, in fact, there are no federal mandates. That's a boogeyman for vaccination. The feds don't have the authority to mandate vaccination. That is a state decision. So if you're mad about your state's decision, don't blame the CDC. The CDC never said, thou shalt mandate the COVID vaccine. Never. So I think just getting that fact out there might be helpful in the misinformation arena. And then, having a legitimate conversation. There are very few people who think nothing, that no restrictions on liberty should be allowed for anything. Um, there are libertarians who are pretty close to that, but not many. Even libertarians like John Stuart Mill believe that some restrictions on liberty are necessary in order to preserve liberty for all. The Jacobson case, right? So the question really isn't, is it ever allowable? The question is, does this qualify and what are our benchmarks? And being more, clear about sort of what are the criteria under which we think that it's okay to implement a mandate. And it's okay to have legitimate debate about that. We live in a democracy and we can have those debates and we get to vote and one side wins and the other side is frustrated until they get to vote again.
Matt, we are about at
Oh,
time.
we're at time, aren't we?
Yes.
Well, thank you all so much for being here for this hour. I appreciate it. And for those of you who don't know, this is, a pretty unique thing to offer a lecture to the first year med students that is also just open to the public. And we have picked the topics for this that we thought would be of interest to the public and of interest to the med students, obviously. But if you've got other topics that you think, ought to be in this series, I think send us a note at the Center for Bioethics and Humanities, and we'll work on doing some more of these.
Thanks, Matt. Thank you to everybody for joining us today. You'll receive the short survey in your email. Take care.